Hello, my name is Michelle Peacock. This is the second lecture on hemodynamics. The first one it was about lines and devices, and this is going to be specifically talking about the management of hemodynamics. When managing hemodynamically unstable patients, we need to remember all the factors which affect cardiac output. I really like this image because I think it does a good job of kind of demonstrating the determinants of cardiac output. So cardiac output is affected by heart rate and stroke volume. And remember, stroke volume is the amount of blood pumped by the left ventricle with each heartbeat. And there are three things that impact stroke volume: our preload, which is volume, our afterload, which is pressure or resistance, and our contractility, which is squeeze. So all of these things will impact our cardiac output and our overall perfusion in the body. So as nurses, when we are managing our patient's hemodynamic status, we always need to be thinking about the patient's heart rate and rhythm, their volume status, the types of drugs that we use to support hemodynamics, and then if that fails, even some of the support devices that we have to use to stabilize patients. And in this lecture, we're going to talk about each one of these components. The first component we're going to talk about is heart rate and rhythm. So the fastest way to increase cardiac output is to increase heart rate. And this is a compensatory response. So the body detects that the blood pressure is low, stroke volume is low, and that the tissues need more oxygen. So as a response, the heart rate or the heart says, you know what, I'll speed up. If I speed up, then I can pump out more oxygen-rich blood. Now, in the short term, this is normal. I want you to think about exercising. When we exercise, our heart rate and our blood pressure go up. When the exercise stops, our heart rate and blood pressure return to that baseline. The problem comes is when our tachycardia, our increased heart rate, is prolonged. Why is this a problem? Well, prolonged tachycardia is not efficient, and more importantly, it's not sustainable. So some of the complications that we see with a rapid heart rate, and by rapid heart rate, the medical community sees rapid heart rate as a heart rate greater than 120. So what are some of the complications? Well, we see a decrease in cardiac output due to a shortened duration of diastole. So remember, during diastole, our heart should be resting and refilling. When it doesn't get this time to rest, it results in decreased coronary perfusion and decreased ventricular fill time. So the harder that the heart has to work, the more oxygen it is consuming. And of course, our oxygen supply cannot meet the oxygen demand. So over time, an increased heart rate will lead to decreased blood pressure and decreased stroke volume. What are some causes of heart rate and rhythm issues? Now, I'm not going to go over all of the causes or go into detail of them. I just mention this so that if you're in clinical or in future lectures, you can go back and say, oh yeah, I do remember us talking about that briefly. So fever, sepsis, many times we do see atrial fibrillation with sepsis. With anemia, pain, and anxiety, sometimes we see sinus tachycardia with that. I know we just talked about increased heart rate. What about bradycardia? What causes that? We have medications are kind of the main cause, like beta blockers. And then also aortic valve surgeries we see on the cardiac floor. When we place that new aortic valve, it causes a lot of swelling and kind of can disrupt the internal electrical pathway of the heart, which would lead to a bradycardia or junctional rhythms. Treatment. So let's just make this really simple. If the heart rate is too fast, we need to slow it down. So what are some ways that we can slow down heart rate? We can use beta blockers like metoprolol. We can use calcium channel blockers like diltiazem, or cardizem is the brand name for that. But the thing with both of those is that when you give those medications, they're also going to lower blood pressure. Now, if you have a heart rate that's going too fast and a blood pressure that's already low, these medications may not be the best choice, or you may have to give them blood pressure support while you're giving these two medications. However, a medication like digoxin is a positive inotrope. Digoxin is used in atrial fibrillation. And what's nice about digoxin is that you can slow down the heart rate but not affect the blood pressure. And this is a medication that is used in atrial fibrillation. Amiodarone is an antiarrhythmic drug, another drug that we use in atrial fibrillation, but this is also a medication that doesn't impact blood pressure. And then finally, cardioversion, which is technically a device, but this would be like in an emergency situation. For example, if a patient was in the ER in supraventricular tachycardia, SVT, and their blood pressure was like in the 60s. Like there's no way at this point in time, if their heart rate's 210 and their blood pressure is in the 60s, like we can't really give medications. We need to shock them out of it. And that's what cardioversion is. Then on the flip side, treatment for if the heart's going too slow, we got to speed it up. And some of the medications that we can use to speed up medication or speed up heart rate, atropine, which is a medical emergency drug, dobutamine, dopamine, and then a pacemaker, which is technically a device. The second thing that we're going to look at is volume. And when we're talking about volume, what we're talking about is preload. Preload is the amount of volume in the ventricle at the end of diastole. So what clinical measurement of preload do we use? That would be central venous pressure, a CVP, and that normal value is between 2 and 6. Now, there is a caveat here. CVP is considered not the best indicator of fluid responsiveness. And even though it's not the best indicator, it's definitely more accessible than other fluid indicators. And that's one reason why hospitals use this, is because they may not have the finances to obtain more expensive equipment that gives them better hemodynamic numbers, but they can do a CVP because a CVP comes off a central line. So that's why a lot of times we're using CVP. The other thing to think about is I said that the normal range is 2 to 6, but let's think about our patient population. Is our patient population in the critical care setting normal? No, right? These patients are in critical condition. So while your number that you get on your monitor may be between that 2 and 6 range, you may think, oh my gosh, I have a normal CVP. Why is their blood pressure still low? It might be normal, but the CVP is not therapeutic. So we need to remember the difference between a normal result and a therapeutic result. So you may have a CVP that's 3 and your blood pressure is in the 70s, in which case that's not normal. It's not therapeutic. We need to give our patient more volume and get their CVP higher in order to support their blood pressure needs. So just something to think about, normal versus therapeutic. Okay, so when we're talking about hemodynamics, our priority intervention is to first evaluate the fluid responsiveness of the patient. We do this with a technique called the passive leg raise. So passive leg raise is looking at stroke volume, and stroke volume is considered a more accurate indicator. So we start the patient up in a semi-recumbent position, and we get our baseline stroke volume and data. And then we put their head down and elevate their feet. And we do this for about 2 to 3 minutes, and we get new data. And what we're looking to see is we're looking to see what the stroke volume variable is. If the stroke volume variable is greater than 10%, that patient is fluid responsive. If the stroke volume variable is less than 10%, that patient is not fluid responsive, which means that they would need another treatment, such as drugs, to help support their blood pressure. Okay, so what are some causes of volume? So for a decreased preload, so a CVP less than 2, our most common causes are things like hypovolemia, arrhythmias or loss of atrial kick like AFib, aflutter, junctional, as well as venous vasodilation. What are some causes of increased preload? Our most common one is fluid volume excess that we see in heart failure. Okay, so let's think about treatment. Again, let's keep this simple. If we don't have enough volume, we got to fill up the tank. So how do we fill up the tank? We do this through fluid resuscitation. And we can use things such as normal saline or lactated ringers, albumin, or blood. All of these things can help fill up the tank. However, if our problem is that we have too much volume, we need to empty the tank. We empty the tank. One way is through diuretics. The next component of hemodynamics that we need to consider are drugs. And when we're looking at how to support blood pressure, we should be thinking about afterload. Because remember, afterload is the amount of pressure or resistance that the ventricle must overcome to eject its blood. So what clinical measurement looks at afterload? That would be systemic vascular resistance, also known as SVR. A normal range for SVR is between 800 and 1200. So if our patient's SVR is less than 800, this patient is more vasodilated. If our patient's SVR is greater than 1200, our patient is more vasoconstricted. So again, let's look at different causes of this. What can cause a decreased afterload? So this would be an SVR less than 800. The biggest problem can be found as a metabolic state, acidosis. Acidosis causes the vessels to dilate. We often see this in septic shock or sepsis and septic shock, different other types of shock. And then in the cardiac surgical population, we see this after patients go on the cardiopulmonary bypass machine after surgery. They have this, what's called vasoplegia, where basically the vessels themselves are like paralyzed and don't squeeze anymore. So these are some common causes of a decreased afterload. What are some common causes of an increased afterload? So this would be an SVR greater than 1200. Well, we see this in hypertension, specifically hypertensive crisis, and another cardiac condition would be aortic stenosis. Treatment. Again, let's just make this simple. So if we do not have enough pressure, we need to increase the pressure. So if we are dilated, we need to constrict. How do we constrict? Well, we use certain medications like norepinephrine, which is Levophed, phenylephrine, which is Neo, vasopressin, epinephrine, and dopamine. On the flip side, if we have too much pressure, if we are too constricted, we need to dilate. And how do we do that? We do that through the use of vasodilators, such as nitroglycerin, nitroprusside, nicardipine, which is a calcium channel blocker, beta blockers like metoprolol, ACE inhibitors, which is lisinopril, or any medication that ends in pril, or if they can't tolerate an ACE inhibitor, an ARB, which would be something like losartan that ends in sartan. When looking at drugs, we also need to look at the contractility. So contractility is the ability of the heart muscle cells to shorten or contract. Looking at the clinical measurement of contractility, you'll find that there is no direct measurement like we see with preload and it being like our CVP, or afterload being our SVR. Contractility really doesn't have a direct clinical measurement that we get from our devices. What kind of causes affect contractility? Well, one is if we have a decreased contractility, we'll see again that acidosis likes to really cause problems. Myocardial infarction, which is a heart attack, and cardiac tamponade when the heart's actually being squeezed um, with blood and it can't actually pump very efficiently. Those are all examples of decreased contractility. Examples of increased contractility, certain types of cardiomyopathies, one being hypertrophic cardiomyopathy, especially in the later stages of that disease, and restrictive cardiomyopathy. Both of those, the heart is squeezing too much and not having enough rest. For treatment, just making it simple again. If we have a decrease in contractility, right? If our heart is not squeezing enough, we need to give them drugs to make the heart squeeze harder. And how do we do this? We do this with epinephrine, dopamine, dobutamine, norepinephrine, which is Levophed, and calcium chloride. All of these are inotropic drugs, really helping that heart squeeze. On the flip side, if our problem is that we have too much squeeze, if we have our contractility is too high or increased, we need to lessen that squeeze. And we do that through beta blockers and calcium channel blockers. The last component of hemodynamic management is devices. Now, we're not going to talk about this too much because these devices require specialized education, like once you've become a nurse and you work on these floors that see these devices. So we're not going to talk too much. I just want you to show them in case you see them in clinical. So the intra-aortic balloon pump, or we just call it a balloon pump, is typically seen with afterload issues. So the balloon sits in the aorta, and it's timed to inflate and deflate opposite to the normal cardiac cycle. So it opens during diastole, which pushes blood back through the coronary arteries. And the whole point of this is to increase the oxygen supply to the heart. And this whole process of inflating during diastole and deflating during systole is that it reduces the left ventricular afterload and again supplies more oxygen to the heart. So the balloon pump we usually use for afterload issues. The ventricular assist device, also if you have it on the left side, it will be called a left ventricular assist device or an LVAD. And if it's on the right side, it's a right ventricular assist device or an RVAD. But we use this for contractility issues. So in this situation, this is the picture on the right-hand side. You can see that little hook in the left ventricle. It pumps blood to the body and bypasses that left ventricle. There's actually a motor there. And by doing this, this motor pulling this blood up and giving it to the rest of the heart, or sorry, the rest of the body, this allows the ventricle time to rest and recover. If we have a patient that is on one of these devices, either the balloon pump or the ventricular assist device, these patients are not doing very well. That means that we've already tried things like volume, we've tried things, like the certain types of drugs, and those treatments are not working. So many times our patients will be on one of these two devices plus all the other things that I've already talked about. Okay, so take a few minutes to read through this case scenario and answer these following questions, and I will address the answers on the next slide. Okay, so what assessment findings did you see that were abnormal, and what's the significance of those abnormal findings? Hopefully you noticed that the patient was unresponsive and they were unable to protect their airway, so they were intubated. Also, you should have seen that the patient had a decrease in urinary output and also had cool skin. So these assessment findings indicate that we have a perfusion issue. In the scenario, it just says that the patient is hypotensive with unknown cause. And this is typical in nursing. Sometimes we have a patient that is not doing well and we don't have an official diagnosis yet. And this is where it's important to understand concepts because while you may not know what's going on in this patient scenario, as far as having an official diagnosis, you do know that they have a perfusion issue. And so you as a nurse are going to do focused assessments based off perfusion, as well as treatment based off perfusion, what you know of perfusion. What hemodynamic parameters are abnormal in this case study? Hopefully you noticed the heart rate and the blood pressure were abnormal. Considering the patient's abnormal hemodynamics, what nursing intervention should be done to determine the plan of treatment? So remember, the priority is to evaluate the patient's fluid responsiveness, and we do this using a passive leg raise. If that passive leg raise showed no response, so if that stroke volume variable was not greater than 10%, then the next priority would be to support blood pressure using medications. And then last question, what is the priority nursing intervention when utilizing an art line or arterial line? That priority is we need to level and zero the transducer at the phlebostatic axis. So remember, in order to get an accurate reading, the transducer must be in the correct place. So if the transducer is lower than the phlebostatic axis, your blood pressures are going to read falsely high. And if your transducer is higher than the phlebostatic axis, your blood pressures are going to read falsely low. Again, I'll have you just take a look at this case scenario, and we'll talk about the answers on the next slide. Okay, so what are the signs and symptoms of heart failure? Hopefully you noticed that the patient was experiencing severe shortness of breath, hypoxia despite having supplemental oxygen. There's also crackles in the lung bases, +3 pitting edema. Their CVP is 13, and their BNP was 50,000. Which hemodynamic parameters are abnormal and what's significant about these abnormalities? So the blood pressure was abnormally high, the CVP is high, and the stroke volume is high. So we have too much preload and we have too much afterload. And then the other thing to consider was the respiratory rate is high. And so this patient is not only in cardiac distress, but they're also in respiratory distress. So what are priority assessments with this patient? So always thinking ABC. The first one is we would need to address that hypoxia and that respiratory rate. This patient would need more respiratory support than they're currently receiving. And then as far as treatment of the preload issue, so they have too much preload. Again, if there's too much volume, we need to empty the tank, and we empty the tank using diuretics. And the afterload is too high. So again, if we are too constricted, we need to dilate. So we would use a medication, vasodilators. In this case, I'm guessing something like nitroglycerin or nitroprusside would be used. What priority nursing management, what is a priority nursing and management for a PICC line? That would be infection prevention. This ends the presentation of management of hemodynamics. This is my reference page. If you have any questions at all, please don't hesitate to reach out.